Good morning. Thank you for joining us once again. For over 100 days, we have been battling COVID-19 around the world. Let me begin by providing you with a snapshot of the current epidemiological situation and trends we have observed across the 53 countries in the WHO European region. The storm clouds of this pandemic still hang heavily over the European region. Case numbers across the region continue to climb. In the past 10 days, the number of cases reported in Europe have nearly doubled to close to 1 million. This means that about 50% of the global burden of COVID-19 is in this region. Sadly, over 84,000 people in Europe have lost their lives to the virus. Of the 10 countries in the region with the highest numbers of cases, there have been optimistic signs in terms of declining numbers in Spain, Italy, Germany, France and Switzerland in recent weeks. But small positive signals in some countries are tempered by sustained or increased levels of incidence in other countries, including the UK, Turkey, Ukraine, Belarus and the Russian Federation. The next few weeks will be critical for Europe. The impact of this virus has darkened all our lives. My thoughts and deepest sympathy are with those grieving from the loss of loved ones or who are seriously ill themselves. And I send my heartfelt gratitude to those on the front line in health and care services who are keeping services operating, working relentlessly to save lives. I would also like to express my thanks to everyone for adhering to the national and local measures and restrictions in place over the last holiday weekend, and appeal to all to continue following these as we approach Orthodox Easter in the coming days. Make no mistake, despite the spring weather, we remain in the midst of a storm. Several countries are yet to feel its full impact, while others are experiencing a dip as numbers of new cases of COVID-19 are falling. It is imperative that we do not let down our guard, but physical distancing, lockdowns and other measures to slow down and stop transmission are affecting lives and livelihoods. People are rightly asking, how much do we have to endure and for how long? In response, governments and health authorities must come up with answers to identify when, under what conditions, and how we can consider a safe transition through a gradual shift in measures. New WHO Regional Office for Europe guidance will be released at the beginning of next week. I will be sharing the key points of that guidance with ministers of health from the 53 member states of the WHO European region tomorrow morning. I am very grateful to the independent European Strategic Advisory Group on COVID-19 for their feedback and input last Tuesday, and to the Director Generals for Health in the region for their comments yesterday. As we consider transition, we must acknowledge there are no quick wins. Complexity and uncertainty lie ahead, which means that we are entering a period where we may need to rapidly adjust measures, introduce and remove restrictions, and ease restrictions gradually, whilst constantly monitoring the effectiveness of these actions and the response of the public. Ultimately, the behavior of each of us will determine the behavior of the virus. This will take perseverance and patience. There is no fast track back to normal. Any steps to ease restrictions and transition must ensure, 1, that evidence shows COVID-19 transmission is controlled. 2, that public health and health system capacities, including hospitals, are in place to identify, isolate, test, trace contacts and quarantine them. 3, that outbreak risks are minimized in high vulnerability settings, particularly the elderly homes, mental health facilities and people residing in crowded places. 4, that workplace preventive measures are established with physical distancing, hand washing facilities, and respiratory etiquette in place. 5. That importation risks can be managed. And 6. That communities have a voice and are engaged in the transition. My single overriding message: if you cannot ensure these criteria are in place before easing restrictions, please rethink. COVID-19 is unforgiving and has shown the ability to overwhelm even the strongest of our health systems in Europe quickly. If countries do not have adequate all of society and all of government preparedness and response strategies in place, if your health workforce is not trained and equipped and protected, if your citizens are not informed and empowered with evidence-based information, then the pandemic will sweep through your communities, businesses, and health systems, taking lives and livelihoods with it. Watch, learn, and listen to each other, particularly the countries that are already taking steps to ease restrictions and transition to a next phase of response. Solidarity is key here, between the health authorities and COVID-19 response leads in the respective countries. In conclusion, we remain in the eye of the storm. When we put proven measures in place, ensuring that we can identify, isolate and test all suspect cases and quarantine and monitor the health of all close contacts, providing care to those who need it, together with physical distancing measures if necessary, we can stop the virus in its track. Any steps to transition towards a new normal must be guided by public health principles, together with economic and societal consideration. We learn better together. Now, more than ever, I call for solidarity between countries. It is the time to step up and display both responsive and responsible leadership to steer us through this storm. Thank you.
Thanks very much, Hans, and thanks for that opening statement. So we're going to open to questions now. Thanks to those of you that have submitted your questions in advance. I'm going to intersperse those questions through the live questions that we take now from the group. As I introduced earlier, we have a panel today of the Regional Director. We also have Katie Smallwood and also Natasha Azzopardi-Muscat joining us online. And I'll be sending them the questions according to the topic. So I'm going to open and I'm going to go straight across to Camilla Hodgson from the Financial Times. Camilla, are you there? Can you hear us?
Hello, yes, can you hear me?
We can. Please go ahead.
Great, thanks so much. I was just wondering, you mentioned new guidance for Europe just now that you'll be speaking to some health ministries about tomorrow. I was wondering if you could just elaborate any more on what that guidance is in relation to.
That's great. Thanks very much, Camilla. I'm going to send that question straight over to Natasha Muscat, who's joining us. Natasha, could I have your response to that, please?
Thank you, Rob. Good morning. As the regional director just outlined, there are the 6 criteria that need to be in place in order to move towards transitioning. The guidance that we will be sharing with ministries tomorrow is around the considerations that countries need to take when embarking on transitioning. And the way in which we are seeing this is as a combination of looking very much at the measures related to surveillance and control, the measures related to health system capacity, which has to balance both keeping up with COVID care, as well as responding to the pent-up demands and needs and getting health systems really recovering to take up their functions, leveraging social and behavioral insights to make sure that we are really listening to the population and engaging them as we move towards the transition. And finally, really having a view on the social and economic measures that need to be in place in the coming weeks and months to protect the vulnerable and make sure that we do not leave anyone behind. So it's basically about having this helicopter view and ensuring that all these 4 dimensions are very much on our data dashboard as we move forward to this next phase. Thank you.
Thanks very much, Natasha. We'll go to the next question online from Jamie Keaton, Associated Press. Jamie, you there?
You can hear us?
Yes, I can. Can you hear me?
Yes,
we can. Please go ahead.
Thank you very much. Dr. Kluge, thank you very much for having yet another press conference. I really appreciate it. My question has to do with, you just mentioned a little while ago, solidarity. As you may have noticed, the signals out of Washington, President Trump has announced a halt to funding. So my question for you is, what kind of solidarity are you hearing from European countries that may step forward to help fill up any funding gaps left behind from this US halt of funding to WHO? Thank you.
Thank you, Jamie. Let me first and foremost state that the United States of America have been a very long-standing supporter and friend of WHO, and I count very much that this will continue in the future. For 25 years, I myself have been working on the ground with humanitarian and health crises. When we have a crisis, we focus on what needs to be done and save lives. And particularly with institutions like the US CDC, I have been seeing how many lives of vulnerable people, thanks to the support of the people of America, have been saved. We have been receiving, indeed, in fact, we have been overwhelmed by the support of European countries, but also people of Europe and all over the world to the mission of WHO. We are looking at the finance situations. Some commitments have come in, but for the time, we are in the midst of the crisis. So what we focus on is to save lives. From the very beginning, the WHO and its staff, of which I am very proud, has been giving every ounce of its heart and spirit to fight the pandemic. And we will continue to do so in solidarity with science and with real solutions.
Thanks, Hans, and thanks for the question, Jamie. And previous to that, thank you to Camilla also and Natasha for responding. I'm going to go to a question that we received in advance from Mos Appelblatt from the Brussels Times. And this one's for you, Katie Smallwood. It reads, in many, if not most EU member states, the fatality rates in retirement homes is very high. In most countries, there hasn't been enough testing in the retirement homes, and a common view seems to be that the patients there suffer from underlying conditions and don't meet the criteria for intensive care in hospitals. What is your assessment of the situation in retirement homes? Is there a strategy that countries should adopt to protect the elderly and reduce high mortality rate in retirement homes? I hope you got that, Katie. I'll send that over to you.
Thank you very much, Rob. I hope you can hear me. Yes, indeed. And when we hear about the numbers of deaths in retirement homes, it's just tragic. And the situation there in these settings is very difficult to manage. And before I say something specific about WHO's recommendations, I just wanted to highlight that retirement homes combine 2 very distinct types of vulnerabilities. Number one, the residents that are there are vulnerable because of who they are. They're vulnerable because they're of older age groups, and many of them have underlying medical conditions, meaning that they can't care for themselves. But they're also vulnerable because of where they are. And retirement homes and other closed settings often are prone to explosive spread of diseases because of overcrowding, because they're areas where a lot of people are coming in and out. There's a lot of contact between people. So combining these 2 types of criteria, retirement homes are very high risk, and we really need to put a lot of attention into them. In terms of our WHO recommendations, we recommend that older age groups are treated with particular care, and in terms of clinical recommendations, as vulnerable groups, we recommend that they're hospitalized if they're detected as positive for COVID-19, or if indeed they're suspected for COVID-19. But of course, these decisions are taken on the basis of the patient and the treating physicians. But measures that need to be implemented for the residents themselves, those that are coming into the homes, particularly those who are discharged from medical facilities. For visitors coming in, very clear risk assessment procedures need to be in place for any visitation, but also for staff. Many of the staff in retirement homes may also be practicing clinicians in other facilities, and we need to be very careful about how they're practicing. So what is the objective here? Well, the objective certainly needs to be to prevent the virus from entering those homes. And if it is entering the homes, to very quickly prevent its spread. And how do we do that? Well, of course, testing is a very significant part of this. And we're seeing countries now expand their testing capacities, and these need to be applied to settings like retirement homes as a priority. Without knowing that the virus is there, there's very little we can do to really respond to the situation very quickly. And then the second thing that we really need to do is protect both the residents of those homes, but also the staff working there. And that's through training on infection prevention and control and adequate equipment based on the training that they've received. Thank you very much.
Thanks.
Thanks very much, Katie.
Thanks for that
comprehensive response. I'm going to go next over to Antonio Neves from the Lusa News Agency. Antonio, your question, please.
For lifting the more restrictive measures. This roadmap includes only 3 criteria, and I would like to ask you, does it make sense to have such a regional framework, and do you think that 3 criteria are insufficient? Thank you.
Antonio, forgive us, we missed the beginning of your question. Can you just repeat the entire question? We missed the first couple of seconds of the question. Thanks.
Okay, I'm referring to the European Commission's roadmap for lifting the more restrictive measures. So I would like to ask Dr. Kluge, does it make sense to have a regional framework for this, and if the 3 criteria defined are insufficient? Thank you.
Yep, thanks very much, very clear. We'll go over to Hans and then to Natasha to maybe elaborate. Hans.
Thank you, Antonio. So the transition framework we have been discussing with the Senior Strategic Advisory Group on Tuesday, yesterday with the Director Generals, and tomorrow to be presented to the Minister of Health, is a regional framework for all 53 countries according to 4 dimensions linked with data analytics, communication and community participation, recognizing the specifics of each country context, but in fact going even further, like we have been seeing in countries as Italy and Spain, that needs to be adaptable to the sub-national context, particularly in those countries where health systems competencies are devolved. So it is a framework that every country and sub-national level can use in order to ask the right questions as a kind of a checklist. If the country would like to invite the WHO Regional Office for Europe to provide technical assistance to adapt it, we stand ready.
Great. No, Natasha. Would you like to elaborate on that? Or add any points?
Just to confirm and support that this transition will definitely not be a one-size-fits-all approach. But of course, having a common framework of considerations will mean that countries will be using similar measurements, for example, similar triggers in order to decide. And this also helps to build public confidence and trust. But every country, and as Dr. Kluge has said, even within larger countries, there may be also subnational differences, will ultimately have to carry out what is necessarily a risk assessment. And into that risk assessment, we will put the epidemiological indicators, but also very much the public health service capacity to isolate, test, trace, contact and quarantine, and the healthcare capacity. Different countries may have different healthcare capacities, and therefore the buffer that countries will be ready to work with could be different, both between different countries and over different periods of time. At the same time, we understand that it is very important that we try as far as possible to use similar language and give similar messages so that people in different countries can understand better the basis upon which the decisions in their own country are being taken, because we feel that this is very important to build public understanding and trust. Thank you.
Great stuff. Thanks very much, Natasha. I'm going to go over to Sarah Newey from The Telegraph next. Sarah, can you hear us?
Yes, I can. Can you hear me?
Great, we can. Please go ahead, Sarah.
Great. Thank you so much for taking my question. My main question at the moment is, it seems from what you've been saying about care homes and about exit strategy this morning, testing really essential to the approach. Why do you think some countries have been much more effective at ramping up testing more quickly? And what do you think countries can do to accelerate that ramp up of testing and make sure that more tests are able to run on a daily and weekly basis? Thank you.
Great. Thanks very much, Sarah. I'm going to pass that over to Katie Smallwood to respond to. Katie, please.
Thanks very much, Sarah. Yes, it's an excellent question, and it just speaks to the realities on the ground that don't always meet what we want theoretically. We're living in a very difficult situation where there are huge practical barriers to us being able to implement a perfect response, and we need to be aware of that. What we've seen in testing in all countries across Europe that have had cases since the beginning of March is that testing has been ramped up. So we have seen very significant improvements in the capacity to test widely. Of course, WHO's recommendation is that every single suspect case of COVID-19 is tested. But we know that that's not the case. And we know that there are several countries that are doing more testing than others. And this represents partly the pre-existing capacities in the countries to bring into the game all public and private laboratories and the procedures that were there beforehand. But it also represents the availability of reagents, the capacity in the workforce to be doing the laboratory tests, and that's got significant variation. So what I would say is there's no one-size-fits-all response to your question, but each country needs to look at its own capacities. It needs to look at international capacities to be able to support. WHO is providing a large amount of support in testing, both through the provision of reagents to countries that need it, but also in the form of technical assistance to laboratories and laboratory workers to be able to undertake the tests. And then finally, and we hope that this will move in the next few weeks to months, is that we'll have a broader range of tests that have been validated and mechanisms through which we can increase testing. Thank you.
Wonderful.
Thanks very much, Katie, and thanks for the question, Sarah. Okay, so next we're going to go over to Meryat Shalbalieva. Meryat, if you're there, that would be great. Could you please introduce yourself and maybe state which agency or news outlet you're from?
Yes, thank you so much. My name is Meryat. I live in Kazakhstan and I'm a broadcasting journalist from Atomic TV channel. So we are based in the capital of Kazakhstan. And my question is, how much will the WHO suffer from the Trump administration decision to cut its budget? Which countries contribute to the organization budget more than 5%? Does Kazakhstan contribute? And if yes, then how much?
Thank you very much, Meryat. I'm going to pass that to Dr. Kluge, Regional Director.
Yes, the share of the United States is about 15% of the WHO budget. It's an annual contribution of about $450 million. So at current, the financial experts are overlooking the financial situation. As I mentioned previously, we're overwhelmed by the expression of support, not only of European countries, but globally. At the same time, this would not be the good moment to cut the funding as we are in the midst of the crisis, and that's what we're doing, WHO. We are laser focused for the time being on saving lives and leaving no one behind. And we count very much that our long-standing supporter and friend, the United States of America and its people, will continue to support WHO.
Wonderful. Thanks very much. Next, I'm going over to Ryan Hooper, PA. Ryan, can you just also introduce what outlet? Forgive me if I'm not getting that abbreviation. Can you hear me? Yes, we can, Ryan. Please go ahead.
Hi, thank you very much. A question for the panel. Thanks for doing this. What are your thoughts, please, on requiring the requirements for a vaccine to become available in a widespread situation before social distancing or lockdown measures across Europe are relaxed, particularly in countries like the UK, where lockdown measures are very much in place and due to be extended? Thank you.
Great, thanks, Ryan. Over to Katie. Katie, can you take that? And then maybe Natasha would like to elaborate with regard to the transition component of that question.
Thank you, Rob. I'm happy to take it and happy for Natasha to elaborate. So with regards to the vaccine, no, WHO is not saying we need to wait for a vaccine. We don't know when a vaccine will be available for use in our populations. And what we need to do is take action now based on the epidemiological situation now. What's very important is that any measures that are relaxed or shifted are done according to the criteria that Natasha has already outlined, and that we think of ourselves in a period of a new normal until such a time that a vaccine may become available to us. We know that there are over 70 vaccines currently in trials, that there's a huge push in the research and development community to move forward. But we're also aware that in reality, we know that it normally takes several years for a vaccine to be developed. We will try and push this as fast as possible, and we're currently looking at 18 months, but we can't predict when exactly a vaccine will become available, and we can't wait for that.
Natasha, anything to add to that?
Thank you, Ryan, and thank you, Katie. The only thing I would add is, of course, the vaccine is going to be most important, particularly for the high-risk and vulnerable groups. And in terms of the gradual and phased transition, we will be recommending that as far as possible, countries take a stepwise, incremental approach and start with those measures that are considered to be based on the modeling estimates to have lower risk, and the backloading, the easing of measures that are deemed to be more risky, particularly where vulnerable people and their shielding and cocooning is concerned. Of course, we are actually calling it transition because we are entering a phase and we do not know how long this phase is going to be. One of the aspects that we are considering going forward is very much to have our eyes on the ball, carrying out horizon scanning, because this is going to be informing the approach also to transitioning in every phase. And just one other point perhaps that I would like to add is that although we are going forward gradually and cautiously with the transition phase in those countries that satisfy the criteria and appear to be ready to do so, this is not necessarily a one-way street. We do not know exactly what is going to happen as the measures begin to be eased, and there needs to be real-time monitoring in place so as to be able to have this fluid bi-directional shifting of measures if this becomes necessary. Thank you.
Thanks very much indeed, Natasha, and thank you to Catherine also for responding. So you mentioned technology there. We've got a question that was sent in advance of this press briefing by Laura Spinney, who's a Paris-based science journalist for The Guardian and New Statesman. And the question relates to technology, about the role of technology in easing lockdown restrictions and preventing a second wave. What kinds of technology are being considered and perhaps even rolled out already? I think I'll send that over to you, Regional Director, if I could first. Hans?
Yes, the role of digital health here in easing the restrictions has certainly an important place. But let me start to put the core of the prevention and control strategy, which are non-pharmaceutical basic public health measures to isolate, trace, test and quarantine. So this remains the same. So the digital solutions have definitely their place, but as part of a comprehensive public health strategy, not as the magic bullet point. Also to take into account the privacy issues, which WHO has been working with for quite a while. But to give some examples, we have been seeing in many countries, including in Spain, in Italy, apps, for example, which are very helpful to tell us something about the level and the location of the transmission, about the effectiveness of physical distancing measures, and also to guide on gradually decreasing the restrictive measures, but as a part of an overall public health strategy.
Great, thanks very much, Hans. I'm wondering if Natasha, would you like to add anything to that? As you brought up technology earlier, can I just ask you?
Sure, Rob. I think it is very clear that there is a role for digital technologies. It does not substitute the traditional public health methods, but it can support and act as a surge to the capacity for certain monitoring, and particularly for real-time monitoring, which is going to be so necessary during the transition. Of course, again, here we do understand that people may have several concerns about the data protection and privacy, and it's very important also that as far as possible, such apps are based on a voluntary opt-in mechanism with very clear and simple consent, and that any data that is captured would be held for a very limited time and destroyed. So all the general principles that we would usually refer to in terms of privacy and data protection are very important also in this scenario. But we do appreciate that there is a role for the appropriate technologies.
Great, thanks very much for those responses. So I'm next going to go over to Dennis Rowland from WSJ. Denise, forgive me, Denise. Denise Rowland from WSJ. Denise, are you there?
I am. Can you hear me?
We do.
Fantastic, thank you. Yesterday, United Healthcare announced that Andrew Whitty, chair of the boss of their Optum unit, is joining WHO temporarily to lead a vaccines project. I wondered if you could give me more details on this. Is this WHO seeking to start a new vaccine research project, or is this about, assessing the dozens that are underway to do sort of prioritize support? And also, why was it important to bring in an industry person like Sir Andrew for this job rather than pulling from internal resources? Thank you.
I'm going to go over to Katie to respond to that. Katie, could you give us a response to that question, please? Thank you. Thanks, Denise.
Thank you very much. Denise, I can't tell you specifically I'm not aware of the specific role for Dr. Whitty in this process, but what I can say is that there's a lot of work already ongoing within WHO on vaccination, specifically around COVID. One is principally on the R&D side, so development of the vaccine itself, but there's also a lot of planning that's already started within the House into how the vaccine would be rolled out globally, and the major challenges, both in terms of public health, but for industries that may be involved in the production of vaccine, how that could be scaled up. It's not unusual at all for WHO to be working with the industry for vaccine production. In the context of influenza and other viruses, we have very regular meetings involving all industries in terms of composition to align the different industries and to really plan rollout of vaccine, scale up of production in accordance with public health needs. Thank you very much.
Thanks very much, Katie. Okay, so we'll go over to I don't know if it's a Mr. I don't have a Christian name or a first name for Singh from Extreme News. Singh, can you introduce yourself, please?
Good morning. It's Karma Singh from Extreme News in Germany. I'm not the editor-in-chief, but he doesn't speak good English, so he asked me to do this for him. Anyway, the question is in three parts, actually. Part one is, in view of the fact that you've many times called a pandemic when none existed, and you have never shown a causational connection between a putative flu virus, which you have now twice renamed and now called SARS-CoV-2, but only a circumstantial connection combined with the fact that the death figures in total are well within the normal range for flu, when are you going to abandon this farce and call off the fraudulent pandemic? Part two, who has given orders to health authorities in Italy and New York especially to artificially inflate death numbers and why? Part three, who has given orders to claim that empty hospitals around the world are filled to overflowing and why? In points 2 and 3, I'm asking for the names in order to facilitate criminal prosecutions.
Thank you. Thank you very much, Rama, and thanks very much for standing in for the chief editor in this case. I'm going to pass that over to Katie Smallwood to answer that as best as possible. It was fairly, there are three different and rather convoluted questions there, Katie, but I'm going to hand the floor over to you to do your best in responding to them, if I may. Thank you.
Thank you very much. So, of course, we declared this the first ever coronavirus pandemic. It's not an influenza virus, so it's certainly a coronavirus, and it's shown that as compared to seasonal influenza, it has a much more significant case fatality rate, which seems to show, and this is data that we have from multiple countries, multiple contexts, and multiple regions, that it has the possibility to cause severe disease. We've seen in the European region in particular, over the past several weeks, significant increases in all-cause mortality. All-cause mortality in several countries in the European region. And this is based on standard, routine, weekly collection of mortality data across European countries. And we've seen significant differences in the rates over the past couple of weeks. And we continue to monitor those reliable and authoritative databases for morbidity and mortality. Thank you very much.
Thanks, Katie. Rama, I really welcome you to send us your questions in writing to the European Regional Office. We'll do our best to respond to you in detail to those questions. So I'm going to move on. We move on to, we have Jung Yoon Choi from KT News. Jung Yoon, are you
back? Can you hear us?
Hello.
Hey,
Hello.
Hi, we can hear you.
Okay.
Go ahead.
Thank you. Hello. I'm the journalist of Korea Textile and Fashion News and came from Republic of Korea, as known as South Korea. So South Korea has suffered serious face mask shortage a month ago, but now the situation has been stabilized. I heard that lots of European countries still have a hard time with mask shortage. So nowadays, lots of Korean sewing factories do not produce clothing, and instead they manufacture face masks for Europe and other countries. So how does WHO handle mask shortage problem in Europe area?
Katie, we'll go
back to you, Katie, on the PPE shortage question. This is specifically to masks, as I understood it. Katie, please.
Thank you very much for the question, and it's great to see industries really refocus their work in support of COVID-19, and I think WHO would continue to recognize in a broader sense. With regards to the specific question around masks, I think we need to be careful when we speak about masks. There are several different types of masks, including medical masks and cloth masks that are used differently and applied and used for different types of population groups and used differently culturally in different settings. With regards to medical masks specifically, WHO's position here is that we do see a continued global shortage, and we are working through our global supply chains to really make sure that we can supply countries that need all PPE, including medical masks, effectively. And that's starting to improve now. And we're seeing small improvements in that process. With regards to who should be wearing them, WHO's position is that medical masks should be prioritized for healthcare workers, for those who are sick, and for those who are caring for people who are sick. And we don't currently recommend their use in broad populations. However, when they are used, they need to be used as part of a much broader set of individual protective measures that are really based on infection prevention and control, washing hands, avoiding contamination with the face, and coughing and respiratory etiquette in terms of covering your mouth and or using a tissue when coughing or sneezing. So thank you very much.
Great. Thanks very much, Katie. And next we'll go to Kat Lay from The Times. Kat.
Oh, hello.
Hi.
I wanted to ask if there was any evidence that childhood vaccination programs were being hit by the response to the pandemic, and if so, what governments should do in response to that. And perhaps more broadly, how much weight should be given to the unintended consequences of lockdown policies on other health conditions when countries are thinking about moving into transition?
Okay.
Thanks very much for that, Kat. I think I'll take the first part of that question and then I'll throw it over to Natasha to talk about the other extended impact. So regarding immunisation, of course, very concerning. A phenomenal burden from COVID-19 that is stressing even the most well-developed and mature health systems, as the RD, our regional director, said in his opening statement. There is this crowding out taking place at the moment, which means that routine services are not able to deliver at the same efficiency and effectiveness as they have in the past. And of course, immunisation, notably childhood immunisation, fits into that in terms of the services that are not being delivered as they were previous to this pandemic. So in this respect, it's very concerning for us because children cannot become an extended burden, if you like, of COVID-19. We cannot allow that to happen. We have to assure that these services are delivered as best they can be during these quite extreme and phenomenal times that we're living through at the moment. So we do have evidence from across the region that this is impacting the pandemic, and the response to COVID-19 is impacting childhood vaccination programs. The key point here is that on one side we have the services that are struggling to provide the services. On the other side, we have the parents that are very concerned, of course, to take their very young children, often very young children, into services and into the centres, and to, of course, come out into the public and go to the health centres to have their children vaccinated. So it's both sides of the story that we need to take into account here. There are some examples where safe zones have been established to continue routine services. But I should say, from the regional office standpoint, we are deeply concerned about this. We do not want the children to miss these vaccines, of course, and be affected by vaccine-preventable diseases, possibly now and, of course, later in life if they've missed the vaccines that are scheduled according to their national schedules. But on that point, I'm going to hand over to Natasha to say a little bit more about the crowding out that we're seeing take place. Natasha, please.
Thank you. Just to fully reiterate the concerns that you have mentioned, we have been concerned about the crowding out, and we have tried to provide also some assistance and guidance to member states by publishing a series of briefs, including a brief on essential health services, which should be maintained as far as possible, even during the height of a crisis such as COVID. And childhood immunization services is considered as one of these key essential services that should be maintained throughout. Nonetheless, we fully understand that country health services have had to refocus and prioritize COVID. And now, as we start to see already that there are some adverse effects, part of the transitioning guidance will be in fact devoted to this concept of continuing to provide COVID care as necessary, continuing to remain vigilant and keep a high level of preparedness, but also ensuring that the routine health services come into play and recover as well as possible. One of the other points of concern that we have seen is that even in those countries where they have been able to maintain the capacity to continue to provide routine healthcare services, they have seen a drop in attendances, for example, at accident and emergency. They have seen also, for example, drops in people presenting even with chest pain or presenting very late with cardiovascular symptoms. This is, of course, very worrying, but we are working to try to identify those barriers that are keeping people away from accessing the health services. And we are trying to find ways in which, as we move to transition phase, we create the configurations to ensure that we have as safe as possible patient pathways so that people can feel confident to come forward for the health services that they need, so that we can start to deal effectively with the pent-up demand that has accumulated over the past weeks. Thank you.
Thanks very much, Natasha, and thanks, Kat, for the question. So next I'm going over to Tom Magner. Tom, can you introduce yourself, please?
Yes, I'm Tom Magner, presenter of Carers Questions on carersworldradio.com. Thank you for taking my question. It's a health question, if I may. The fire services in the United Kingdom are urging people not to have bonfires, at least during the lockdown. Viewers on carersworldradio.com, many of whom are family carers at home classed as vulnerable, are asking the following. Is there a link or effect between COVID-19 and wood smoke? If so, in summary, as best you can, what is that evidence? And finally, can you give a message to those ignoring UK fire services advice not to burn wood?
Thanks very much indeed, Tom. Katie, I'm going to ask you to respond to Tom, please.
Thank you, Tom, for the question. The response would be that we should all be following the advice of our local authorities, which is taken in discussion with health authorities, but also other sectors such as the police, fire brigade, first responders. And these decisions are not necessarily taken because bonfire or wood smoke have a direct causal link to the disease itself, but because they may distract resources from essential services. They may encourage people to congregate in groups, which is against the current advice of the authorities in place. So we would certainly recommend that each of us take our responsibilities quite seriously in this event, and that the behaviors we should be showing are examples to others in our communities, and that we all have this very key role to play, and the decisions we take and the advice that we follow will actually determine the spread of the disease.
Thanks very much, Katie.
I'm going over to Gabriela Sotomayor. Gabriela, welcome back from Mexico, Proceso. Gabriela, are you with us?
Thank you for taking
Thanks.
I have a question. I was late a little bit. I don't know if it has been asked, but is there any estimate of how many health workers have been infected in the region and how many died from COVID-19? Thank you.
Okay.
Thanks very much, Gabriela. I know that we do have some data on that. I'm going to pass the floor back over. Sorry to put it on your plate again, Katie, but that's over to you again, Katie, please, to answer Gabriela's question regarding healthcare workers and burden within healthcare worker communities.
No problem, Rob. Thank you, Gabriela, for the question. Of course, we're very concerned about the high rates of infection among healthcare workers. They're particularly vulnerable, and we need to put all our efforts into protecting them and keeping them in the workforce. Certainly, they should not be working if they're sick. In the European region, we're following the data that we have from all of the countries that report based on case-based data. And sometimes we have full details within those cases. And on the basis of approximately 300,000 case-based report forms that we have received, we have documented that 1 in 13 cases are among healthcare workers. This is a very high number, but it needs to be treated also with some caution. There is a testing bias towards healthcare workers. It's much more likely if I'm a healthcare worker working in a hospital or in a medical facility that I will be tested for the virus as compared to the general population. So yes, we are seeing high rates of healthcare worker infections. This is a concern, but also we can't read too much into those numbers before we have much more information about the general population.
Thank you very much, Katie. Thank you. We have a question from Bayram from the Anadolu Agency. Bayram or Bayram?
Hi, thank you. Thank you very much for giving me this opportunity. This is Bayram Alto. I work for Anadolu Agency and based at United Nations Geneva office. My question for Mr. Hans, as you aware, Turkey sent medical supplies to UK 2 times, and Spain, Italy, Balkan countries, and many other states in the Europe and across the world last couple of weeks in order to help them to fight against the novel coronavirus. On the other hand, Turkey is also fighting against the pandemic itself, as number of cases has reached almost 70,000 there. So what do you think about Turkey's commitment and solidarity to provide essential medical supplies to many European countries and others? Thank you.
Thank you, Bayram. About 10 days ago, I had a 1-hour conversation with the Minister of Health of Turkey, specifically on the COVID-19 situation, and also we signed a new 2-year agreement and expressed my appreciation on behalf of WHO for the solidarity by the Turkish government, because indeed we're very well aware of the support. And I always say what happens in one country and the support that WHO is providing to one country is useful for the country, but is as useful for the whole region and beyond. This is a new virus, so the solidarity you expressed is very important. We are learning every day. The knowledge we gain, whether it is in Turkey or other countries, serves us all. So this is the kind of solidarity that we are seeing more and more in the WHO European region, and which is very hopeful. Thank you.
Great. Thanks very much, Hans. We have a question from Konstantinos Davanis. I don't think I've asked this of Natasha so far on this call. From the Hellenic Public Television in Greece, who asks, are there countries in Europe that will be based on the epidemiological picture that exists and with the measures that have been taken, ready to lift the restrictive measures and resume at a normal pace? Is Greece among these countries? That is from Konstantinos Davanis from the Hellenic Public Division outlet in Greece. Natasha, please.
Thank you, Rob. Thank you, Konstantinos. I think I would like to start by repeating a phrase in this question, which is around resume at a normal pace. I think it's very, very clear for us as we consider this transition phase that this is not about going backwards, going back to normal. It's about going forward into as yet an unknown new normal. And I think it would be really helpful also if all the media outlets can help us to communicate this clear way in which we are seeing it. In terms of the countries and their preparedness, I go back to the criteria which the regional director outlined at the start of this call, the 6 criteria, but generally it's about having the right epidemiological information in terms of a declining number of new cases, but also in terms of the fact that with the number and rate of new cases being seen, the healthcare system, the public health capacity is clearly there and is able to cope. It's also, however, about having the larger overview and the larger picture in mind. In other words, the population, how they are feeling, how they are responding, how they are adhering, and also the socio-economic picture. And therefore, some countries we know are very much thinking and planning their transition. And the key message is to ensure that the epidemiological picture is stable, is declining, to make sure that there are no outbreaks in these institutions, for example, that cannot be controlled, but also really to make sure that the healthcare buffer capacity is very much in place, and that, for example, the PPE, the supplies are in place, that the workforce has rested, has recuperated, and is ready to be able to cope in case there is an unexpected resurgence of disease, which would happen very rapidly. And therefore also really key in this transition is the data dashboard, which as far as possible is really based on real-time data. Thank you.
Thanks, Natasha.
Would you like to add to that?
Yes, I think that was excellent how Natasha showed that the WHO framework can be applied to each country's specific context, and I wanted to reassure you, Konstantinos, that we are in regular touch with Minister Vasilis Kikilias and also with the special envoy of Prime Minister Mitsotakis on COVID-19 for international organizations, Professor Elias Mosialos from the London School of Economics and Political Science, who in fact is one of my strategic advisors, including on developing the transition framework. So it's a win-win for Greece and for the region, and what I see is that Greece is tackling this also in a very evidence-informed manner. Thank you.
Thanks very much, Hans. Right, on that note, we're going to close this press briefing. Very happy that you could join us today. Please do join us again, same time next week. In the meantime, take care, stay safe.